push the button on top until it turns green. There you
Okay. I thought red meant on. All right, so can everyone hear me?
Yes.
You can hear me in the back. Okay, awesome. Thank you so much for that introduction, and also thank you for the invitation. I am really excited to be here, and this is one of my favorite topics. And so I guess I wanted to first find out a couple things. So who here has never heard of GLP-1? I think that you would have to try really, really hard to have never heard of GLP-1s. They're kind of everywhere. So, and then I guess who here, if you could give me a show of hands, who here is in healthcare?
In healthcare.
Is or was? Yeah, in healthcare. Awesome. And then who here has ever prescribed a GLP-1? Okay, I'm not going to ask who's on one. So, all right. So that's the topic. So I'm going to start with, actually, I'm going to back up a little bit. And so, so here's my outline. My outline has a lot of topics. And so I'd like to get on the same page and talk about diabetes and obesity. I'll talk about what GLP-1s are, how they work, or how we think they work, what they do. So there's a number of different really, really great clinical trials that have demonstrated different effects. And then some more kind of weight loss specific effects. I categorize those at the end. Some potential effects on the brain that are being studied, and then what those caveats are, the adverse effects and precautions, and then some things just a peek into the future. So really stepping back. So I wanted to show this diagram. This is everything that I do, which is the pancreas. So beta cells are cells in the pancreas, and the pancreas is, of course, an organ that kind of lives deep in your abdomen. And what I tell people that I'm trying to teach about the pancreas is that it's kind of deep in your abdomen, away from being able to be damaged, because it contains things that digest food. And so you wouldn't want to injure the pancreas and digest the insides of your abdomen. And so it's really, really protected. So usually when people have car accidents, or they have surgeries or other injuries to the pancreas, it can really cause a lot of problems, because the pancreas contains digestive enzymes, but then it also makes a lot of hormones. So beta cells are cells in the pancreas that make insulin, and they kind of are grouped into these little things that we call islets. And insulin, of course, is a hormone that helps us metabolize food. And the reason that insulin is called a hormone is that kind of definition of a hormone is a protein that's made in one part of the body, goes into the bloodstream, and then kind of travels somewhere else to have its effect. And so that's what insulin does. So the pancreas makes insulin when our blood sugars are high. So this is, if you take a look at this graph, this is insulin levels on the y-axis, and then meals, or kind of time on the x-axis, and breakfast, lunch, and dinner. So every single time we eat, so in this case it's breakfast, lunch, and dinner, then your insulin levels go up to try to handle the meal. But the thing is, the pancreas also makes insulin when your glucose isn't elevated. So it's also making insulin kind of all the time. So that's kind of what we call basal level insulin, and that's kind of in these green circles. And so that's actually, it's because we always need a little bit of insulin. It keeps us out of diabetic ketoacidosis, kind of keeps things coming along. And so it's not, digestion, metabolism, it's all a lot more complicated than that. And so besides insulin, besides glucose, of course, there's also a hormone called glucagon. That's made by alpha cells in the pancreas. And those are, because the body is so finely tuned, it's pretty amazing. When the body has production of one thing, it's making, there's always some counterbalance. And so if our blood sugar goes down, then our body actually makes glucagon to try to deal with that and bring our blood sugars up. So it's kind of a counter-regulatory hormone for insulin. And so the normal response to eating is your blood sugar goes up, and then your insulin levels go up to deal with that. And then your glucagon, which is the counter-regulatory hormone for insulin, is suppressed. So that's the normal thing, is that your insulin goes up, glucagon goes down. And I mentioned, these alpha cells, these beta cells, here's the islet, so just a group of these specialized cells in your pancreas. And so just a quick word that today is actually World Diabetes Day. I did not realize that when we chose this day, and I think it's just really perfect. And so World Diabetes Day, November 14th every year, and it turns out November is Diabetes Awareness Month here in the US. And so unfortunately, the prevalence of diabetes is predicted to continue increasing worldwide. And so this is kind of a color-coded map of the world, and this kind of predicted increase from 2024, so these data are from the Diabetes Atlas from 2024, and then the percent increase is in 2050 in different parts of the world. So kind of worldwide, the incidence or prevalence of diabetes actually is expected to increase by 45% worldwide by 2050. And then when we take a look at different countries, there are certain countries where the numbers are especially stark. For example, in Africa, the number is expected to increase by 142%. And then the Middle East, 92%. In North America, 21%. And one of the things, so I've been focusing on diabetes my entire medical career. And I finished medical school in 1996, did my residency and finished it, did a chief residency in 2000. And basically every time I would see these predictions, all these predictions, because they would say, oh, you know, here's our predicted prevalence of diabetes in 2010, 2020. And what's happened is that every single time you see these predictions 20 years ahead of time, it always seems like they're overestimates and they're overblown. People are being alarmist, like what assumptions were they making? It seems inaccurate. And it turns out that when we would actually get to that time point, those were underestimates. And so that's the problem, is that things are accelerating. And so the prevalence of diabetes in US adults is very high. So diagnosed diabetes, probably about 29%, so it's 11% of people. And all diabetes, undiagnosed and diagnosed, probably make up about 15% of US adults. And then there are 96 million, so estimated 96 million adults in the US with pre-diabetes. And 43% of people with all diabetes are age 65 or over.
Is that 1 and 2?
Sorry?
Is that diabetes
Yes,
1 and 2?
yeah, that's
Okay.
all together. And it's because when they do these, this is a CDC, these are CDC data, they actually can't really break it down. So, and then actually we've had a lot of problems with misclassifying lately. But I'll show a slide in a second, but we think that type 1 probably makes up about 5 to 10% of the total. And so type 2 is probably around 90 to 95%. But then there are all these other kinds of diabetes too. But yes, all combined. And then it turns out that about a third of US adults who are 65 and older have diabetes. So it's a huge percentage. A third of people 65 and older have diabetes, and about almost 50% have prediabetes. So it's a huge, huge issue. So what are we talking about when we're talking about diabetes? Of course, I'm talking about diabetes mellitus, not the other kind, diabetes insipidus. And so diabetes, has anyone heard of diabetes insipidus? Yeah, so some people have heard of that. It was really confusing, you know, to call this other condition diabetes too. It's basically when people urinate too much for kind of a hormonal reason. But diabetes mellitus is what I'm talking about here, and that's what most people are talking about when they're talking about diabetes. And so this is it's an umbrella term. And so just like so many conditions, like it's actually pretty heterogeneous. And so not everyone is the same, not every type is the same. So it's actually a pretty heterogeneous group of disorders. And the only common thing among all these disorders is the blood sugar is high. So that's the way that we kind of lump people into and then call them having diabetes mellitus. So what happens is that when people have elevated glucose because of dysregulation, I'll talk about the causes for that in a second, then the normal thing is when your blood is passing through your kidneys are trying to filter out toxins, so you urinate those out, but then everything that's good, or everything that's useful, is reabsorbed. And so glucose is actually considered a good thing because it gives you energy. And so normally your kidneys should be reabsorbing all of your glucose. But the problem is that there's actually a threshold where if your blood glucose is too high, so the concentration of glucose in your blood is too high, and that blood is passing through your kidneys can't reabsorb all the glucose that the blood has above a certain blood glucose level, and then that glucose ends up getting urinated out in the urine. And so along with all that glucose that gets urinated out by kidneys that can't reabsorb the glucose is a lot of water. And so kind of the way our kidney physiology works is that when there's electrolytes in the urine, then water kind of follows along with it. So that's why people who have elevated blood sugars, maybe undiagnosed diabetes, end up urinating a lot when their blood sugars are high. And so diabetes actually comes from this Greek word which means to siphon. So I have a little picture of a siphon here, it's diabanon. And mellitus is Latin for sweet. And so there's a piece of candy here. And so diabetes mellitus is a chronic health condition that affects how our body metabolizes food into energy. So it's not just glucose. Glucose is the easiest thing we can measure. We can't really measure protein levels or fat levels that easily. And so glucose is kind of what we focus on because we can measure that pretty easily. But it turns out that there's also dysregulation and dysmetabolism of protein and fat too. It's all of metabolism. So I mentioned at the beginning, why it's an endocrine disorder. It's because insulin is a hormone, and a lot of this dysregulation has to do with insulin in diabetes mellitus. And I'm an endocrinologist. I specialize in hormone disorders, and diabetes comes from either reduced production of or reduced action of insulin, which is a hormone. So what different types of diabetes are there? So this was brought up before. There are different types of diabetes, and most people are talking about type 2. That's the most common. Probably 90% of people have type 2, and that's non-autoimmune, but it's very hereditary. So genetics play a really strong part. It's this progressive loss of your beta cell production of insulin, and there's almost always insulin resistance, and I'll show you a little more about that in a second. And then it's usually accompanied by metabolic syndrome. Type 1 diabetes is it's caused by autoimmune destruction of beta cells. So the body basically makes these antibodies, and it's actually T-cell mediated too. And the main thing is T-cell mediated, where it kind of mistakes the beta cells as being foreign, and so tries to attack them and destroy them, and then people lose their ability to make insulin. And so people over time lose the complete ability to make insulin. And so there are lots and lots of other causes for diabetes. So people might have monogenic syndromes, maturity onset diabetes of the young, or MODY is another kind of group of syndromes. You could have disruption due to something like cystic fibrosis of the pancreas. You could have pancreatitis, and repeated pancreatitis can destroy your pancreas. You could have medications that affect the pancreas. Actually, a lot of the immune checkpoint inhibitors that might be used for cancer these days could affect and cause diabetes. And then people who undergo organ transplants, especially solid organ transplants, some of the immunosuppressants may also increase the risk for diabetes. And then people are often on high doses of glucocorticoids or steroids, and then that can increase your risk for developing diabetes. And then lastly, there are medications for HIV and AIDS that also, and just the list is extremely long, but those medications tend to cause metabolic syndrome, especially the older ones, and can increase the risk. And then gestational diabetes is women who don't have pre-existing diabetes, pre-existing type 1 or type 2, and then they do their glucose tolerance test at second trimester usually, and then they get diagnosed during pregnancy, because that stress of pregnancy their pancreas can't handle, and their blood sugars go up. And so type 2 is a lot more common than type 1. I mentioned that type 1 is probably 5 to 10% of the total, and then type 2 is probably about 90%. And so one of the other things I wanted to mention is that type 1 diabetes can be diagnosed at any age, and so it used to be called juvenile onset diabetes. It's totally incorrect. And so probably about 50% of people are diagnosed above the age of 30, or 20 actually. And then now, unfortunately, we have adolescents and youth who are diagnosed with type 2 diabetes. And type 2 diabetes diagnosed in childhood or adolescence is a very different disease from type 2 diabetes diagnosed as an adult. It's much more malignant, and it's a lot more severe, and people present with complications a lot sooner. And so I mentioned genes, I mentioned environment, and so if you took identical twins, I'm going to ask for your opinion on this. So if you had identical twins and one of the twins had type 1 diabetes, what are the chances that the other twin is going to have type 1 diabetes, the autoimmune form, kind of the less common form?
50%?
So 50%, 100%, other guesses?
25.
25.
Cover the spectrum.
Okay. So then let me switch the question a little bit. So what about type 2 diabetes? What if that identical twin had type 2? What are the chances that the other identical twin is going to have type 2 diabetes?
Much
Do
lower.
you think it's going to be higher or lower than type 1?
Lower.
So lower chance that that identical twin might have type 2. So really surprising, and actually a fun fact is, not a fun fact, this is proven and kind of studied, is that type 1 diabetes, autoimmune, juvenile onset, actually the chances are only 50%, so it's 50% concordance. So 50% chance that the identical twin might have type 1 diabetes. For type 2 diabetes, it's 80%. And so it's a very, very strongly inherited condition. That doesn't mean that we can't do anything about it, but it just means that it carries a very, very strong genetic risk. But the thing is, people have been searching for a single gene or a couple genes, but it's a polygenic disorder. So there are many, many genes that confer that risk. So I mentioned insulin resistance, decreased insulin secretion by the beta cell. And so how does type 2 diabetes develop? I mentioned those two things. And so insulin resistance, and have people heard of insulin resistance? Probably heard it everywhere. It's like also a really, really prevalent term, I think. Basically, insulin resistance just means that you need more insulin to get the same effect. So your body's resistant to the insulin. So that results in high insulin demand. So what your body tries to do is your pancreas tries to make a ton of insulin to try to overcome that resistance. And so then you get these high levels of insulin in your blood. And that is good because initially it keeps your blood sugar okay, keeps it normal. But unfortunately, those high levels of insulin over time are not a good thing throughout your body. And so what causes insulin resistance? So there are lots of different factors, but probably one of them is obesity. And that's considered a very huge risk factor for type 2 diabetes. And I'll show you kind of a map of the US in a second. And then also, if you have fat that's depositing in your organs, so for example, in your liver, in your muscle, so those are things that can increase your insulin resistance. And type 2 diabetes, pretty much everyone has insulin resistance. And that's felt to develop and then kind of stay the same throughout the course of your diabetes, unless you do something about it. And then the beta cells. So you cannot get diabetes without beta cell failure. There's just no way. If your beta cells, your pancreas, could make enough insulin that your body needs, to keep up with that demand, you'll never get diabetes. It's just when the beta cells fail or they become insufficient that your blood sugars start to go up. So there has to be both. There's insulin resistance and there's beta cell insufficiency, beta cell failure. And so what causes that? It's actually a lot of the same stuff. And so ectopic fat, when it's in the pancreas, or other different conditions can cause decreased function, inflammation, beta cell death, early death, and decrease in beta cells, decreased beta cell production. And there are a lot of things that can cause both of these. So inflammation, and there are many, many different things that can increase inflammation. And I think the final common pathway might be oxidative stress. But there are many things that increase oxidative stress, increase inflammation, things like stress, things like eating certain foods, I guess, especially just consistently eating what they call the Western diet, so a high saturated fat diet, not getting exercise or not being physically active, taking glucocorticoids long term. I mean, there's so many different things. And then now we know that the gut microbiome probably plays a role too. And so in type 2 diabetes, we know that there are so many things that are dysregulated. I mentioned insulin, I mentioned glucagon. We also know that there's this thing called an incretin response. So I'll talk about incretins in a second, but this is also dysregulated in type 2 diabetes. And so this is just, people without diabetes on the left, people with type 2 diabetes on the right, and you can just see this blunting of insulin secretion in response to food in people with diabetes. And so I guess now I want to ask you, so what is GLP-1? Yes, yeah, it's a hormone, yeah.
Glucagon-like peptide.
What's that?
Glucagon-like peptide.
Yes, absolutely, awesome. Glucagon-like peptide 1. Cool. And then, what are people talking about when they're talking about the GLP-1s? Yeah, exactly. So it's an incretin, and incretins are hormones that are made by cells in the gastrointestinal tract in response to anything that you take by mouth. Could be anything you drink, could be whatever you eat. And so another incretin is GIP, gastric inhibitory peptide. And as mentioned, GLP-1 stands for glucagon-like peptide 1. And there's some different names that have evolved over time as people kind of first isolated it years ago, thought there was something up with it, and then they've kind of given it different names. So if you actually read the older literature, it had different names. But usually a lot of people when they're talking about the GLP-1s, they're talking about the medications, GLP-1 receptor agonists. And so these two incretins augment or cause more insulin secretion, but the cool thing is that they only do it when your blood sugar is high, not when your blood sugar is normal. And so this was, when these came out 20 years ago, that was actually what we were the most excited about, because we had only the medications that cause your blood sugars to go low if you were on too much or if your body didn't need as much. And this was like a whole new class of medicines that could treat diabetes, but it wouldn't cause low blood sugars. So that we were super excited about that. So just wanted to mention this thing about the agonist. So I said a GLP-1 receptor agonist. So just a quick little picture about agonists and antagonists. So agonists are drugs or substances that bind to a receptor inside a cell or on a cell surface that cause the same action as that same substance that normally binds to the receptor. So in other words, we have GLP-1 receptors, we have GIP receptors, and so GLP-1 receptor agonist is just a drug or substance that also binds to that and then stimulates that action. An antagonist is something that binds to it but then inhibits the action. And so when this was all first kind of figured out, it was really very cool. This is back in 1987, the original papers on what GLP-1 did. And so these effects of GLP-1 on insulin were discovered by Dr. Mashoff. She found these effects in the pancreas, and then Dan Drucker, his name I think is kind of all over the place as well. He found out that this was GLP-1 was in islet cells, and that they were glucose dependent. So he really made some key discoveries. This was back in 1987. And so how does GLP-1 act on the pancreas? So GLP-1 binds to that receptor and acts on the beta cells and then acts on delta cells, which indirectly stimulate the alpha cells. So that's kind of how GLP-1 works in the pancreas. And so it regulates glucagon production, it regulates insulin production kind of through some different ways. But this was the other cool thing back when these first came out, is that we were excited about the fact that GLP-1 receptor agonists, these drugs, didn't just lower blood sugar one way, there were multiple different ways that it was normalizing people's glucoses. And one of it was affecting food intake. And then another was this thought that when people have type 2 diabetes, sometimes the food kind of moves too quickly through their stomach. And so then your body actually can't handle that very well, and so maybe slowing it down is a good thing. And so it's thought that if it moves through too fast, then it just causes increased blood sugar, or it's more likely to increase your blood sugar. So here's what I was trying to say about diabetes and obesity. So this is from the Behavioral Risk Factor Surveillance Survey that the CDC has been doing for the past 30 years or so. And so what they were doing is basically calling several thousand families up and asking them a whole bunch of questions. And so they would ask them how tall they were, how much they weighed, whether or not they had diabetes, and then like a whole bunch of other questions. And so this data has been tracked over time. So just looking at the prevalence of obesity and the prevalence of diabetes over the past 30 years or so, you can see these state-by-state maps, and you may have seen this before. But this epidemic that we're talking about, kind of that prevalence of diabetes that I was talking about worldwide, you can kind of see it here. And so people actually, when they were drawing these graphs, they had to keep adding these squares on the end because the prevalence just kept going up higher and higher and higher. So originally, when they first drew these maps, they didn't need these higher ones because the prevalence was pretty low. So it's just been crazy. And you can see that this prevalence and kind of that geographic map of where diabetes is kind of tracks with where obesity is happening across the country. And everyone always, everyone outside Colorado is always pointing to Colorado and saying, what's up with Colorado? But I think that we're catching up. And so some of the latest maps, I think we're still a single state there, but I think our outdoor lifestyle and other things definitely help. So how do we cause type 2 diabetes remission? And so I never talk about cure because I think that once you've gotten diabetes, you're not really curing, like you can't really cure it unless you do something about your pancreas, maybe if you do something about all the other things. It's actually very hard to cure it, but you can make it go into remission. And so if you lose quite a bit of weight, you can actually, and it's early enough in the course of the diabetes, you can cause type 2 diabetes to go into remission. And so this was a study of just lifestyle. And I'm showing this because I wanted to show you kind of that this is possible without drugs, but the drugs can do it too. And so in this particular study, people underwent really, really intensive lifestyle interventions, and it was a pretty long-term study. So they looked at year 1 data and year 2 data, and they kind of stratified this analysis of these different graphs, looking at participants achieving remission of type 2 diabetes and losing less than 5 kilograms at year 1, 2, losing between 5 and 10 kilograms, 10 to 15, or 15 or greater. And so you can see that the chances of type 2 diabetes going into remission are much, much greater if you lose 15 kilograms or greater. 10 to 15 kilograms, like the more weight you lose, the more likely you can make type 2 diabetes go into remission. So these are the kind of data that have kind of informed some of the recommendations and guidelines that different societies are giving now, which is that if the purpose of the weight loss is to cause diabetes to go into remission, then you actually need to lose probably 10 to 15% of your weight. So the average weight in this trial was 100 kilograms to start. A quick word also, because I think this comes up, is not all fat is the same. And so the American Heart Association put together this thing that they call cardio-kidney metabolic syndrome, or CKM, a couple of years ago. They tried to pull together all this data that we have, this evidence that we have that the risk for heart attacks and strokes and heart failure actually tracks in this syndrome. And so oftentimes people have metabolic syndrome, they have type 2 diabetes, and or they might have chronic kidney disease. And all of that gives you this really high risk of heart attacks, strokes, heart failure. And not all fat is the same. So dysfunctional adiposity is when you have too much visceral fat, so fat that's in your organs, and it's called ectopic. And then also fat around the heart and other places. And then also when you have lots of inflammation and insulin resistance. And so one of the concerns has been kind of GLP-1s causing loss of muscle mass, right? I don't know if you guys have heard of that. So people losing too much weight, they're losing muscle mass too. Is that a really bad thing? And so there's been some really careful studies that I won't go into, but when you read about these actual studies, there are a lot of nuances and kind of understanding what the definitions are. And so they might be talking about fat mass, they might be talking about muscle mass, or they might be talking about fat-free mass. So fat-free mass is not muscle mass. Fat-free mass actually includes muscle, bone, and connective tissue. So all of those things can affect our cardio-kidney metabolic health. And so when you have too much fat in your organs, that can promote toxic or lipotoxicity, too much oxidative stress, and chronic inflammation. And then when you lose lean muscle mass, which that's the concern when we're losing too much weight with the GLP-1s, is losing lean, good muscle mass, that can increase your risk of cardiovascular disease and death through insulin resistance. And about almost 50% of people, so 40 to 45% of individuals with obesity actually have sarcopenia too. And so they have age-related loss of muscle mass and decreased strength. So that's sarcopenic obesity. So now turning to kind of back to the GLP-1s. So there have been these major milestones. I mentioned 1987. And so that first drug, 2005. So that was 20 years ago. So this is the 20th anniversary of the first GLP-1 that was approved for type 2. So I started using these kind of after my fellowship. And then there's kind of a different class of DPP-4 inhibitors like Januvia and I can't remember the trade names of the other ones that are also based on this pathway. And then this class of drugs, they were first approved for type 2 diabetes, and then about 10 years later were approved for obesity, and that was a huge earth-shattering thing. And then I was on the FDA Endocrine-Metabolic Advisory Committee when we heard the data about semaglutide or Ozempic, and the company was presenting this information to the advisory committee and to the FDA about whether or not semaglutide or Ozempic could reduce your risk of heart attacks and strokes. So that, when that came out, that was also earth-changing. Like, we just couldn't believe the information. Like, it was not expected. It was really surprising and really great. So that was the first positive cardiovascular outcome trial for this class of medications. And then, of course, about 3 years ago, we had kind of this co-agonist, GLP-1 medication, and so that's Mounjaro and Zepbound. So I'm using these generic names just because we're not really actually allowed to use trade names when we give talks on campus and to professional societies. But I think that the problem is that most people don't know the generic names when they hear them. And so I have this little list here. And so I have the GLP-1s on the left. They're actually the GLP-1 drugs by themselves. There is a GLP-1 in combination with certain basal or long-acting insulins, kind of next. And then there's that double agonist or dual agonist that I mentioned at the end. And so the generic names are kind of here. Semaglutide, tirzepatide are kind of the two that I'm going to talk most about. But there are different names for semaglutide. There's 3 different names, because there's one name for diabetes, one name for obesity, and then one name for the pill form of semaglutide. Ozempic, Wegovy, and Rybelsus. And then for tirzepatide, that dual agonist, there are also 2 names, one for diabetes, one for obesity, Mounjaro and Zepbound. And then I won't talk about the SGLT2 inhibitors, which have also really changed what we can do for people. And then I'm definitely not going to talk about this class, because the only good thing about that class is that they lower blood sugar a little bit. They don't have a lot of side effects, but other than that, and they're really expensive. So we really try not to use them. So this is kind of the class I'll be talking about. And so what do they do? So thank you for bearing with me, because I wanted to go through all of that background before we started talking about what they do. And so first thing is, we know that semaglutide, or Ozempic, is very, very effective for lowering hemoglobin A1C. And so this is, if you look at all the different papers that are published, what you see is, kind of A1C on the y-axis, and then time on the x-axis. And so here, people are starting out at an A1C of about 8.2%, so that's not usually at goal. And then they're going down to about 6.4 compared to placebo. So placebo is the line on top, and then the 2 different doses of semaglutide are on the bottom. So people are going from an A1C of 8.2 down to about 6.4 within about 20 weeks. So, and then it's kind of staying there. Another way that people show the data are what % of people are getting to target. And so the target A1C might be less than 7%, or it might be less than 6.5%, kind of depends on the person. For some people, the A1C target might be higher. But here in this paper, what they showed is that on the higher dose of semaglutide, and actually, I'm sorry, they studied the weight loss dose of semaglutide in type 2 diabetes, so it's a little bit confusing for this paper. But about 78% of people on the highest dose of semaglutide were able to achieve an A1C of less than 7%. And about 67.5% were able to achieve an A1C of less than 6.5%. So it's really, really, we've never had medications like this except for insulin. So really amazing data. Tirzepatide, that dual agonist, also lowers A1C in type 2. So in this particular trial, people started out, they tested different doses, 5, 10, 15, and 15 is the max dose, and they compared it with semaglutide, 1 milligram. And so people started out with an A1C of 8.3%, and within about maybe 20 weeks, everyone's A1Cs came down below 6.5%. So all of these drugs are extremely effective at lowering A1C. And then on the right, what's pictured here, pretty complicated, is what percent of people on the different doses got to at least 5%, 10%, or 15% weight loss. And so you can see, even at the lowest dose of tirzepatide that was studied, 5 milligrams, 2/3 of people lost 5% or more of their weight. So 5% is kind of a magic number because that's when people's blood pressures go down, their risk for heart attacks goes down. I mean, 5% is a really, really good number to be able to lose that amount of weight, either with lifestyle changes and with medications. So 2/3 of people could get there. When people on the highest dose, 80% were able to get there. But what we didn't expect is that on tirzepatide, people could actually lose 15% or more of their weight. And so that was really approaching levels of weight loss that we've never seen before with medications. And so,
That was on 5 milligrams?
which one?
The one you said losing more than 15% of their weight?
So
That was
there's
on 5 milligrams?
very, very small percentages of people were able to get to the 15% weight loss. And so I'll it's so complicated, let me read it out. So if you were on 5 milligrams, only 15% of people on it were able to lose 15% or more. If you were on the middle dose, the 10 milligram, then about a quarter. And then if you were on the highest dose, about a third could get to 15% or more. So definitely not as much as maybe people want, but far more than we've ever seen with other medicines. So not quite at surgery degrees of weight loss. So then any questions about that before I move on to pre-diabetes? Yeah.
What is the difference between the obesity and the DM models? You had Mounjaro and
Yeah, the different names, nothing. Well, no, I shouldn't say nothing. So for tirzepatide, which is that dual agonist, there's no difference. The doses are exactly the
So
same.
Mounjaro is exactly the same thing as that.
This is a true-false question I was gonna ask later, but yes. They are exactly the same, yeah.
Okay,
And
if
so-
I'm on one and the insurance doesn't cover Zepbound anymore, but they'll cover Mounjaro, that's all I'm saying. What's the difference?
So I think that this is the bias that the insurance companies have against treating obesity and overweight. They're much more willing to treat diabetes than they are, or cover diabetes than they are to cover other conditions. So that's the
Preventive
problem.
versus treating.
Yeah,
Okay.
that's the problem. And so I think that it's been a huge issue. And the differences with semaglutide or Ozempic and Wegovy, those highest doses and the middle doses are different. So, for example, the diabetes doses are 0.25, 0.5, 1, and 2. Those are the diabetes doses. The weight loss doses are a little bit different. The lower doses are the same, 0.25, 0.5, and 1, but then the higher doses go to 1.7 and 2.4. So it kind of goes, it's a little bit different. So just wanted to show some information about semaglutide or Ozempic. Actually, it's not Ozempic. In this case, it was Wegovy, preventing diabetes in individuals with overweight and obesity. So they looked at people with prediabetes who happened to be in these weight loss trials, and then checked to see whether or not being on the medicine could prevent progression to diabetes. And we're talking prediabetes to diabetes. And so what they found, really the main thing I wanted to focus on is just this one number here. So being on semaglutide in the trial reduced your risk of progression from prediabetes to diabetes by 73%. So it really, and this is over the course of about 4 years. So it was really, really an incredible amount. And tirzepatide, that dual agonist, actually reduces the progression from prediabetes to diabetes by 93%. So almost no one who was on tirzepatide went on to diabetes if they have prediabetes at the start of the trial. So it's because of the magnitude of weight loss, we think, but actually it's probably not just the weight loss. And so there's one of my colleagues, Dr. Khan, up at the University of Washington, led this analysis where they tried to figure out, was it just the weight loss that was preventing progression to diabetes, or was it something else? So it wasn't due solely to the weight loss. So first of all, regression and progression really depended on what your blood sugar and glycemia and your hemoglobin A1C was at baseline. And then the amount that losing that weight accounted for progression to diabetes was only about a quarter, and regression about a quarter. And so there are actually some direct effects of the medications on the pancreas. And we kind of know that, right? Because we already thought there were all these different effects. So it's not just the weight loss. Yeah.
Metformin, how does that play into progression from pre-diabetes to diabetes?
That is such a great question. So metformin was studied very, very closely in the diabetes prevention program, and that was published back about 15 years ago. And metformin was shown to reduce the progression from pre-diabetes to diabetes by about a third, so about 32%, I think was the number. But intensive lifestyle intervention in that same trial reduced the progression by about 60-some%. And so lifestyle was a lot better if it was intensive lifestyle interventions. And metformin could also do it. And so we use metformin as well to reduce the risk. And metformin's inexpensive, and there's maybe other effects. So certainly, I think metformin's a good choice. It's not as effective as these drugs, though. So now moving on to kind of the effects of our own GLP-1 and GIP, there are effects on the heart, blood vessels, and kidneys. And so there are receptors for both GIP and GLP-1 on all of these organs. So we kind of expected to maybe see some effects with the drugs as well. So now we have several of these GLP-1s that lower your cardiovascular risk. So I have these yellow arrows here. And there's one more that just came out, that was the tirzepatide trial, that just came out maybe last month or so, that also shows that being on that medicine, if you have existing established cardiovascular disease, lowers your risk of getting another heart attack or stroke.
What was the name of that new one?
It's the Mounjaro.
Mounjaro.
Yeah.
Thank you.
Yeah, and that was studied kind of compared to one of the other older GLP-1s. So liraglutide is kind of the top one here. That the other names are Victoza for the diabetes version, the daily medicine, or Saxenda for the weight loss version. And then the different forms of Ozempic, Wegovy, Rybelsus, and Trulicity also reduces your risk.
So the primary prevention hasn't been really shown yet. Is that just because the length of the trials haven't gone long enough?
Thank you for bringing that up. And so all of these medications that I'm showing you have this FDA indication for secondary prevention. So the FDA indication is for people who have established cardiovascular disease. And the data are strongest for established cardiovascular disease. Many of the trials also included people who are at pretty high risk, and so they have all these different risk factors. And so with those data, usually it was smaller populations, and so they couldn't really, that would be primary prevention. So most of the trials didn't include enough people without established atherosclerotic cardiovascular disease, so they couldn't really prove that. The only trial that does show it is the Trulicity or dulaglutide trial, where about 2/3 of the people in that trial didn't have established ASCVD. So, but they did have all those different risk factors. And so that's why this, FDA decided that they would only give that indication to one of the drugs, not the others.
I have a question.
Yeah.
If you have a very strong family history of cardiovascular disease, would this drug be an indication for as a preventive measure?
We don't know. Yeah, because it hasn't been studied. And so what's interesting is that the older American Heart Association Heart Risk Calculator there's nothing about family history in there. There's a bunch of new calculators. They're called Prevent. There's like Prevent Heart Failure, Prevent CVD, there's different Prevent calculators you can find online that have just been put out by the American Heart Association that start to drill down to some other risk factors. And I can't remember actually if family history is in there, but zip code is in there, interestingly. So I wanted to point out that, it made huge news last year when semaglutide was shown in people with type 2 diabetes and chronic kidney disease to reduce the risk of kidney failure or death from kidney or cardiovascular disease. And so it actually reduced the risk by 24%. So it's really, that was another huge milestone in kind of our being able to take care of people with these conditions. So the ADA decided that they were going to put it into their standards that year, and then in January the FDA approved this additional indication for semaglutide. And so now it's kind of, GLP-1s are a standard part of our different pathways and guidelines for treating people at high risk or people with established ASCVD. And all of my cardiology colleagues are starting to try to figure out how to prescribe these medications as well. So it's really great. And now the kidney doctors or nephrologists are starting to do it too. So what about kind of these, what I consider weight loss specific benefits on sleep apnea and arthritis? And so remember that these drugs were originally developed for type 2 diabetes, but it turns out that the huge prizes were actually given for the GLP-1s and their effects on obesity. And so Dan Drucker, he was considered one of Time's 100 most influential people in 2024, and then that group, kind of his mentor Joel Habner received, and also Dr. Svetlana Mashov got the Lasker Prize for their work in obesity. You already answered this question, but I'm going to ask it anyway, because it is surprising how many people come into my clinic and they're like, I want to be on Zepbound because that's going to work better. Could I switch over? And so, but I mean, there's other issues too, like kind of this whole coverage issue, but kind of, true or false, Zepbound's a more potent weight loss drug than Mounjaro. Of course it's false. They're the exact same thing. So it's the same drug product, different names, different trials, different indications. And so they actually, in FDA's eyes, they're different, but the actual drug is the same. And so, and I think that all of us have been struggling with, how to get these medicines to people when there's all this, the insurance kind of resistance to covering the medications for obesity. And so we were very, very happy to see some of the trials that I'll show you in a second. So we know semaglutide helps people lose weight when they have type 2 diabetes. So here's a trial also kind of using that maximum weight loss dose of semaglutide, where they're kind of looking at percent body weight change over time. So this is percent body weight change on the y-axis. On the x-axis again is time. And the red is the highest dose, the blue is the medium dose, and then the gray, look at how much weight the placebo group lost. So they lost about 3 kilograms, or 3% of their weight. And so people in these clinical trials, even when they're on placebo, they also, have some beneficial effects from all that monitoring maybe. So whenever you're looking at these effects, what we're going to look at is placebo subtracted weight loss, because we want to know what effect did the drug have on top of placebo. And so at about not quite a year, so about 44 weeks, maybe a year, people lost about 10% of their weight. But if you subtract the placebo, then it's about 7%. So it's, I think a lot of people may or may not be looking for that degree of weight loss, but it's medically, health-wise, it's really beneficial. And what about tirzepatide? What about the two going head-to-head? So this is in obesity, so people without diabetes. What happened is that tirzepatide, so this is the Zepbound version, people lost 20% of their weight, and then people on semaglutide, but not the 2 milligram dose, the 1 milligram dose. So we actually haven't seen head-to-head of the highest dose, lost about 14%. And so this is how you can game clinical trials to make your drug look better. So just keep that in mind, is that people may not be paying attention to details like that. And so you can say, oh, well, my drug is better than yours, but then they tested the highest dose of their own drug against a medium dose of another drug. So just something to keep in mind.
That doesn't sound that.
Yeah. And this was actually pretty interesting. So in this particular trial, and this is one of the things I wanted to point out, is that previous information or the bar graph I was showing, and I was kind of going through some of the details on the percent of people who got the 15% or more weight loss. That was in type 2 diabetes. This is in people without diabetes. So one of the other things we see is that all of these drugs are more effective for lowering weight in people without diabetes than people with diabetes. So here, the highest dose of tirzepatide caused 15% or more weight loss in 2/3 of people. And it caused, the highest dose caused 25% weight loss in 1/3. So those are like bariatric surgery degrees of weight loss. And those adverse effects were mostly gastrointestinal, and we'll talk a little bit more about that in a second. And so here's the trial that actually caused the FDA to approve tirzepatide, or Zepbound, for obstructive sleep apnea. They took people using or not using CPAP and looked at improvement in CPAP and improvement in weight. And they saw this huge reduction in the number of what they call apnea-hypopnea episodes overnight, so times when they stop breathing or don't have quite enough breathing, hypopnea. And there's huge differences or decreases in the number of apneic episodes overnight in people who are on tirzepatide. And to the point where some people completely eliminated all of their sleep apnea, or a lot of people went to the mild form from being moderate or severe. And then the body weight changed a lot, so it was about 20%. But placebo subtracted was about 18%. So now Zepbound is FDA approved for moderate to severe obstructive sleep apnea in people with obesity. And then the people who make semaglutide have been testing semaglutide in every condition you can think of. And so one of them is arthritis. And so this was a trial where they had kind of a standardized way to measure pain from knee arthritis. And what they found is that being on semaglutide reduces your pain a lot from knee arthritis. So this is really promising. And the FDA hasn't approved that indication yet, but we're hoping
Is that due because that's due to weight loss? Is it weight
Yes.
loss related, or is it something else that was?
we think it's weight loss.
Same thing with the apnea, it's the weight
Yeah,
loss.
yeah.
It's the weight loss that does it.
And that's why these kind of the sleep apnea and the arthritis, those are kind of in my weight loss section. Because I really think that the effects are from decreasing load on the knees and then probably the effects on sleep apnea. Yeah.
What happens if you don't want to lose weight?
If you don't want to lose weight, but you want to be on these medications, you need to lower your A1C or something.
Yes.
So that is a problem because, and I've been dealing with that with some of the people that I see in clinic as well, is that, we want to keep people off insulin, we want to give them these benefits like on the heart or the kidney, and they're losing too much weight, and I don't want them to lose weight, and so that's an issue. So we can talk about that. I've tried all sorts of different things like using lower doses, encouraging eating, not ice cream, but,
Yes,
things
ice
like
cream.
olive oil, walnuts, and, avocados and things like that. That it can be a problem, but, we look at these dramatic amounts of weight loss, but it's still very individual. So if you look at a individual plot where each person is a bar on a bar graph, the amount of weight that you lose, there's still some people who gain weight on these medicines. So it's very individual. So not everyone loses weight, and a lot of people may not lose a lot of weight. Yeah.
What happens when you stop taking the medication?
So when people have looked at that, and there are a few studies out there of stopping the medication, because a lot of people stop them for various reasons, supply chain issues, affordability, insurance coverage, and there's tolerance. There's like so many different reasons that people stop the medicines. People regain about 2/3 of their weight at a year. That's the average.
A year,
In the year,
12
yeah.
in 1 year.
In 1 year. So that's as far out as the study went, and that was an average. And so the individual effects may vary quite a bit. So, but I think that everyone expects that unless you have something that can sustain that weight loss, then getting off the medicine is going to put the weight back on. So it's just like being on a blood pressure medicine. If there aren't other factors that can kind of keep the blood pressure controlled, then being off that medicine is going to raise your blood pressure again.
So people take this for obesity,
Yeah.
and then they stop the medication. will they gain the weight back because their appetite comes back, or is it the effect of the drug? I mean, will they go back to their regular eating habits if they stop the medication?
I think that's a really good, I mean, we think they will. I mean, because I think that, I think one of the questions you may be asking is like, why do people lose weight on these medicines? So we don't really know why. We think there's some central effects. We know that there's some effects on appetite and what they call satiety, so the feeling of fullness, the feeling of hunger. And so there are some different central nervous system effects, but we actually don't fully understand all the effects on the brain. So it's probably mostly effects on the brain. And then there might be other things, but we think that once you're off the medicines and they wear off, there aren't durable effects that keep lasting on. And yeah, there are a couple of more questions.
Yeah, how about visceral fat? Is it follow the same as total fat, or do they measure it during these tests?
This is still being studied, and so in these particular trials I'm showing you, they didn't do those studies. So all the studies where people are looking at body composition and types of weight that's lost, those are much smaller studies and they're still being done. So right now we don't have the greatest way to measure the quality of muscle mass, quality of fat, like we can't, that still needs to be defined. And so, and I think I talked about that in the slide at the end, but I think those are some of the issues with that this is actually brought up. And what's been surprising to me is why is this issue coming up instead of these issues coming up when people have bariatric surgery? Because people who've had bariatric surgery might lose 25%, 30% of their weight. Like, were we worried about like muscle mass then? No one really brought up that issue. And so I think, I don't know if it's because more people are on these medications and they're seeing dramatic amounts of weight loss and some of it seems to be muscle that we're concerned. But I think that we're still not really sure. I think probably people are losing both visceral and subcutaneous fat. We know that happens with weight loss. They're also losing muscle mass because anytime you lose weight, you're losing all three of those things. It's just we want to try to increase, like we really want it to be the visceral that we're losing. We want to maintain that muscle mass, and we're okay with subcutaneous fat, so because that's beneficial. Yeah.
The percentage of weight loss that we've seen on these graphs, over what period of time is that?
Yeah, and they've been different for different, so most of these have been about 50 some, 60, 70 some weeks. And so those are kind of listed at the bottom. And so most of them haven't gone beyond about 70 some weeks or so.
A year and a half.
Yes, yeah, about a year and a half. Yeah, so they're pretty short term. I mean, they're long term for them because it costs a ton of money to do these trials, but it's short term for our lives. And so here's kind of the pain score that happened in this particular trial is that people's pain scores went down quite a bit on placebo in blue. So actually, people in the placebo group had reduction in the pain score, and actually it improved quite a bit, but people on the medication reduced more. And so it's pretty amazing how much the pain improved on placebo. And this is why it always has to be a placebo-controlled trial. And that's why so many of the kind of the unproven therapies out there, most of them don't have placebos, and so it's because there's always a placebo effect. So onto the brain, and I'm almost done, is that we know that there are all these different GLP-1 and GIP receptors in the brain. These are different parts of the brain. This is the middle brain, hippocampus. And so we think, there are all these effects on appetite and stuff, and so there are probably also effects on things like substance use, kind of addiction, and other things, so we're still learning about that, but maybe even things like this for Alzheimer's. And so there's some ongoing trials of semaglutide in Alzheimer's disease, and Dan Drucker was really, really excited about this. I got to chair the American Association of Clinical Endocrinology annual meeting this past May, and our keynote speaker was Dan Drucker. And we decided he would be a great speaker because it was our 20th anniversary of this group of medicines and on and on and on. And he gave a fantastic talk. And he really highlighted how excited he is about these trials. So we don't know right now whether or not these medications are gonna be beneficial to try to prevent progression of Alzheimer's disease. But these trials are going on, so I'm really excited that they're happening. It's for both the injected form of semaglutide and the pill form. But there's kind of all these different ways that people are trying to predict what the results might be. That's what this target trial emulation is. And so I just had to throw this in here because this target trial emulation where they're trying to model risks and things like that is predicting that maybe semaglutide could reduce your risk of Alzheimer's by 67%.
Wow.
We have no idea what, and this is compared to insulin, and 0.59, so reduced risk by 41% compared to the other GLP-1s. So we have no idea if this is actually true. This is just a prediction, and they're trying to, they have to make assumptions and stuff like that. But we'll see. So on to the caveats. So there are lots of potential side effects. Those GI side effects are what everyone hears about, what people experience. So in the clinical trials, probably about a quarter of people got these side effects. It only caused people to stop the medication maybe 5% of the time. But nausea, vomiting, diarrhea, constipation, they're one of the older forms. People have a lot of injection site reactions, and then it's totally contraindicated if you have kind of a rare form of thyroid cancer or a kind of a thyroid cancer syndrome, MEN2. And so here's Dan Drucker's view of kind of the different adverse effects of the GLP-1 medications. I mentioned the gastrointestinal ones. At first, a long time ago, when these first came out, we were worried about increased risk of suicide. Turns out that doesn't seem to have panned out, but that was a concern. Then, when I was on the committee hearing about semaglutide or Ozempic, unfortunately, that trial that was meant to show safety of this medication and show that it, does it cause heart attacks or not. Of course, that trial ended up showing that there's cardiovascular benefit, but unfortunately, it also showed this 80% increased risk of worsening retinopathy. So what the company has argued is that that worsening retinopathy is all related to this drug being too effective at lowering blood sugars. Because we know that when we lower blood sugars from being too high, so an A1C of 9%, 10% or higher, down to a much lower level, you can worsen retinopathy if you already have retinopathy. We've known that about insulin forever, because we can lower A1Cs pretty dramatically with insulin. I wasn't convinced because the analysis that they presented was post hoc and it didn't really track. And so people have been repeating this whole thing over and over and over without having seen that graph that they showed. And so the company actually has an ongoing trial that should be published. It just finished, so they should be publishing those results in the next couple of months or so. It's called the FOCUS trial. So we'll actually see if it increases the risk for retinopathy. But everything after that, every single GLP-1 trial, every single kind of recommendation you make, we kind of tell people that they need to have baseline eye exam and they need to have regular care with an ophthalmologist or an optometrist when they're on these medications. Because pretty much anything that lowers your A1C dramatically could theoretically increase your risk of worsening retinopathy. Thyroid cancer, I mentioned. Pancreatitis and pancreatic cancer was a concern initially, but that doesn't seem to have panned out. That sarcopenia I mentioned, that's still up for research. We don't know, so we're looking at that. The acute kidney injury actually has more to do with people getting nausea, vomiting, getting dehydrated, and then getting kidney injury. So that's really more related to dehydration. Gallbladder disease, I think, is related to the dramatic amounts of weight loss, because anything that causes dramatic amounts of weight loss will increase your risk of gallstones and gallbladder disease. And then gastric emptying, so retained gastric contents. This is a huge issue that kind of came up this past couple of years in the anesthesia world and the endocrine world, where anesthesiologists are very, very worried when people go, they put them under for a procedure that people will aspirate. And so they don't want people getting pneumonia, they don't want people having to go on a ventilator after a surgical procedure because of something that they did. And so there's a huge concern on these medications because it's slowing your gastric emptying, that it might also be increasing your risk of aspirating and getting pneumonia and needing to be on a ventilator after a surgical procedure. so the American, I think it's called the American Society for Anesthesia or something like that, they put out a statement about a year and a half ago that was extreme, without a lot of data. And it kind of put everyone up in arms about, and the statement they said was, these drugs, you know, can increase the risk of aspiration and pneumonia, all these things I was mentioning. And so people should stop them. And maybe even stop them for a month before surgery. And so everyone got up in arms about that and said, how could you do this? You know, what are we, you know, there's no data, you know, data aren't good, et cetera. So they kind of backtracked and they said, actually that wasn't our intent. And so the bottom line is that everyone now has kind of settled on, and it kind of varies by the hospital, varies by, you know, your surgeon, varies by your endocrinologist maybe, but, and your anesthesiologist, but I think most people are recommending that if you're about to go under anesthesia, that you should hold your dose of weekly GLP-1 for a week or 7 days before that procedure. And for the daily version, which a lot of people aren't on, you can hold it for just a day. And then lastly, maybe it increases the risk that your bowels may not move very well. So here's kind of that whole body composition thing. And so this was just trying to see what the relationship was between the amount of weight loss you can get with a certain GLP-1 and the amount of preservation of lean mass or muscle mass you could get with a GLP-1. And so these are the different GLP-1s at different doses, and what they're kind of show, because what you want is you want as much, like you kind of want to be here. So here is where you have the best reduction in weight and the best lean mass preservation. And it turns out that the winner is not semaglutide and it's not tirzepatide, it's liraglutide, which is available generically now. So this is one of the earliest GLP-1s, the daily medication. So, and then here's that comparison, just kind of the best we have. This is actually a really, really nice paper on this because there's a lot of really bad papers out there. But this one actually tries to show the percent body weight loss kind of in relation to how much preservation of lean body mass. So lean body mass loss on the y-axis, percent body weight loss on the x-axis. And so diet ends up being the best, and then bariatric surgery is purple here, and then the GLP-1s are in green. So maybe there's a slight hint that the GLP-1s cause a little bit more loss of lean muscle. So that's the concern.
But I don't see anything about lifestyle changes, increasing exercise, activity
People
to
should be
counter.
telling you, yeah, I mean, when we're prescribing it, so we don't have the greatest data right now on what's the best way to preserve that lean muscle mass. Kind of intuitively, we think that if you do more weight training, resistance training, eat more protein, you know, do all that kind of thing, that people should be able to preserve it, but we don't have the data to back that up. So, but that's what I tell people. So I tell them that we don't have the data to back that up. But I think it's, right now, it's our best, you know, strategy. So I think it might be the case that it causes a little bit more loss of lean muscle mass, but it might be not very much. And we don't know if this is really true. So that same review in Circulation, which is the leading journal for the American Heart Association, actually this author and this group of authors felt that that muscle mass change could be adaptive. And so they're kind of arguing that we don't really know how to measure muscle mass, like muscle quality. And I don't understand everything that they were talking about in there, but I think that they're kind of lobbying for better ways to measure and then some standards. So we don't really have those right now. So now moving on to cost. This is from the American Diabetes Association standards, comparing cost of things like glipizide, things like pioglitazone or Actos, things like Tradjenta, Januvia, Jardiance, Farxiga, the GLP-1s, and tirzepatide, the dual agonist. And so you can see the relative costs per month here. And so they're all very, very high, unless you're talking about sulfonylureas or glipizide and Actos or pioglitazone. And as I mentioned, we have these generic GLP-1s They're very old, so exenatide was the first GLP-1 that was approved, 20 years ago. Look at the cost. That to me is not, that's not, inexpensive. And that's a twice-a-day medication, the original one. The one that actually has cardiovascular benefit, Victoza or Saxenda, that's called liraglutide. That's also quite expensive. That's a daily one. And so the different companies have discount programs. These are on their different websites, and so there are different costs, and most of them, if you're self-pay, it's still super expensive, but sometimes you can get the price down for a year. And so I've included Trulicity or dulaglutide here, and then this combo GLP-1 with a basal insulin. They have different programs. And so one thing that Rick mentioned to me a few days ago when this presentation was coming up was this whole deal that the White House has struck with some of the drug companies. So I took this from the Reuters website and just pulled out a couple of things that I thought were maybe the most relevant. So these are deals that have been cut to try to reduce drug costs in exchange for tariff exemptions for 3 years. So that's kind of what the company got from doing this. And so for the currently available injectable GLP-1s used for diabetes and other covered health issues, the cost to the government would come down to $249 a month. Those are people on Medicare and Medicaid. And then what they say is that for Medicare patients, the co-pays will be capped at $50 a month. So I think this could really, really change access quite a bit if this comes true. So we'll see whether or not it actually is going to happen. So I'm hoping that would really improve access. This would start no later than January for people who pay cash, and then by mid next year, 2026, for Medicare patients, and then Medicaid kind of depends on the state. What they also said, and I am just shocked by this, is they somehow maybe negotiated expanded coverage for GLP-1s to individuals with prediabetes. That's 96 million people. And people with heart problems, so it's already covered for that. And then also obese patients with comorbidities, I assume that's sleep apnea, severely obese patients, maybe the coverage for obesity will be better, but I have no idea. And so that may be 10% of Medicare patients. So specifically Lilly, they're the company that makes Zepbound and Mounjaro. They say that their lowest dose is going to be $299 a month, so that's the 5 milligram dose. Or maybe it's, I don't know, maybe they're talking about the 2.5. Okay. 2.5. Okay, the 2.5. So the 2.5, all the data I was showing you was not 2.5, it was 5, starting at 5. And then additional doses, which I assume includes the 5, would be $449 a month for people who are paying cash.
$50 off a month.
Yeah.
Yeah, off of the company price.
Yeah.
And the higher doses then would be, if you're repeating, like if you're paying cash and you're paying for month after month, then that cost would go down to $399. So it's still super expensive.
It's still just $50 a month.
Yeah. And then Novo, they're the ones who make Ozempic and Wegovy and Rybelsus. They haven't provided any details yet. And then what's interesting is that what they also negotiated, and I'm like kind of shocked by this too, is that starter doses of a medication, and I'll show you a little bit of data on, so not yet approved weight loss medicines, pills that are being developed would cost $149 a month to the government for Medicare and Medicaid, and to cash payers on the White House site. And then so this can affect millions and millions and millions of people. But this prediabetes one, that's the one that gets me the most. So that has the hugest potential to help the most people. And that's really being preventive. So I wanted to also say a word about disparities in access to all these things that we do for people with diabetes, both who's enrolled in the clinical trials, who has access to diabetes technology, who has access to immunotherapies, so there are a lot that are being tested now, and then who has access to kind of a lot of the technology, adjuvant technologies. So it's a huge issue, and so we're still working on access, and everyone's kind of sounding the alarm on this too. So what's on the horizon? I have never, ever, ever seen a drug that is effective in 100% of people in the trial. So this is a triple agonist that is not approved yet. It's called retatrutide. That is a glucagon, GIP, and GLP-1 agonist in phase 3 or late phase trials. And the phase 2 results show that 100% of people in the trial lost at least 5% of their weight. So this is mind-blowing to me. But what I don't know, and actually I should double check this, is I don't know if this was, so the way some of these weight loss trials are done is there's a run-in period and they only enroll people who lost a little bit of weight at the beginning. So if that's the case, they're gaming the trial, kind of trial design and trying to, but compared to other medications who, that have never showed 100%, this is really game-changing. And 73% of people achieved 15% or greater weight loss on the 8 milligram dose. And then people have also looked at super high doses of the oral semaglutide. Here's that kind of the pill form of weight loss drugs I was telling you about in the White House kind of negotiation. The newest kind of closest one to being approved is called orforglipron. And what's really, really great about this and different from Rybelsus, which is the pill form of semaglutide, is that this is what they call small molecule and it's non-peptide. So it's not a protein. And so it's super easy to make. These drugs are a lot easier to make. You can make them around the world. You can ship them. They don't need to be refrigerated. I mean, there's all these great things about this kind of drug if you can make more of them. And so this is the first GLP-1 receptor agonist that's a non-peptide. And in this phase trial, so this was just published a couple months ago, this also leads to weight loss. And so on the highest dose, about 72% of people lost at least 5% of their weight. And about 18% lost 20% or more. And so we talked about lots of things over the past little while, and I apologize that kind of went a little bit long. And my final thoughts are these therapies are expensive, but the prices might be coming down, and we have these generics, but unfortunately the generics are expensive. Remember that it takes time to up-titrate these medicines, so all the weeklies, you should be on each dose for at least 4 weeks, and that's really to increase tolerability. And so the whole point is to try to make sure that they're tolerable. And you don't have to up-titrate to the maximum dose. It's kind of you figure out what your endpoint is with your doc, and then just get there and then kind of decide how things are going. All these current GLP-1s are injected except for that one I keep, the pill form of semaglutide, but there are a lot that are being developed. Lots of injected ones and some oral ones. There are lots of different targets that are being tested, and then what I said here is don't use these if you have medullary thyroid cancer or MEN2 syndrome. And then I specifically listed the ones that reduce cardiovascular risk, and it's not that they reduce cardiovascular risk in 100% of people. They only tested people either with established atherosclerotic cardiovascular disease or people with high risk. So not everybody. And semaglutide also reduces chronic kidney disease risk if you already have chronic kidney disease. And then tirzepatide has the FDA indication for sleep apnea. Semaglutide has a new indication, because we have new data now, and I didn't show you this, that for people with liver fibrosis in metabolic dysfunction-associated fatty liver disease, it actually reduces that. And so it now has a new FDA indication. And so stay tuned. There are tons more new peptide drugs coming down the pike. When I gave a talk on obesity about 10 or 12 years ago, I saw the pipeline was like 50 or 100 drugs. So now we're actually starting to see all of these drugs come out. So it's pretty cool. So I have, some of the different references, but I put references on the bottom where I found, took all the different graphs and things. And I just wanted to mention I have a 1-year diabetes fellowship training program that I started a few years ago with a colleague and with our coordinator. And so if you know anyone who's doing, training in medicine, med-peds, or family medicine who's interested in becoming a dietologist, please have them contact me. And yeah, I just am grateful to all the different societies I've had the chance to be part of, and to my mentor, Boris Jasmine. So thank you so much for your attention. So I know the time is a little bit late, but I'm happy to stay.
Yeah, time to say
Oh,
it?
absolutely, yeah,
Okay.
definitely.
So let's use the microphone so everybody can hear. We have one question over here. So put your hand up and I'll try to get the mic to you.
So I wasn't sure about the pill form when you were talking about that. When the pill form comes to fruition, do you anticipate to be similar results, better results, or less effective?
So it looks like these results they're not like, they're pretty good, but they're not like earth-shatteringly good now that we have such a good injected medicine out there. So far we haven't really found a whole lot that's better than tirzepatide. The tirzepatide is still quite, it's the most potent thing that we have here. So when you look at these data, this is that medication you're talking about that's not available yet. So these are pretty good data. They're probably on the order of semaglutide, they're not on the order of tirzepatide. So it's looking pretty good. And I think that our standards have gotten a lot higher now that we have such an effective medication that came out 3 years ago. And so I think that what I didn't show you is that there are medications that are coming out like Maritide and some other ones that are actually more potent than our existing drugs.
It looked like all these studies measured weight loss for about 70 months.
70 weeks.
What period of time did they measure side effects?
That entire time.
So just 72 months.
Right.
Weeks.
Yeah,
So
yeah,
that's a pretty short period of time.
yeah, because I think what you're bringing up is a really important point is kind of long-term follow-up studies. And so one of the things that we do know is, the FDA has this adverse event database. And so if we as, people who are seeing people in the clinic are using medications and we see something that's an unusual side effect or a severe side effect, then we report it in this database. It's called a FAERS database. And so, but of side effects that we already know are happening with the medication, we don't usually report those. And I don't know that these drug companies are doing long-term follow-up studies. But I think that one of the other things I should mention is that many of those gastrointestinal side effects, they're the worst initially and they're the worst when you're increasing the doses, but they actually don't, they get milder over time if you can stick with the medicine. So,
Do the side effects go away if you stop the medication?
yes, always.
Has there been any studies on advancing age relative to the effectiveness of GLP-1 advantages?
I don't know of any. So I don't know that they've studied older populations specifically, and I think that what we've seen anecdotally is that it seems like people are, we're really, really careful about causing weight loss in our older patients, especially when either they don't have a lot of muscle mass to start with, or they don't have the weight to lose, or there's other reasons we're worried about nutrition and kind of eating a balanced diet, etc. So there aren't specific studies that I know of, but I think that when we're practicing, in clinic and stuff, we are watching weight pretty closely and trying to use lower doses, etc.
Okay, one last question.
Thank you for your presentation. What's your opinion about the research availability drugs that are out there at a much lower cost?
Say that one more time.
There's product out there that comes in a powder form and it's research based. It's not prescribed from a drug company.
Oh, research based, you mean like the compounded?
Yes.
Yes.
Okay.
Pharmacy.
Guess what? I have a slide on that. So, for a while, I think for a couple of years, maybe it was a year or two, the FDA actually approved, thought it was okay to have compounded versions of the medicines because there was a huge supply chain shortage.
Right.
And then the FDA said, no shortage, these things, you can't do that anymore. And so, they're not legal. The FDA doesn't really have time to go after all the different compounding pharmacies. And I think one of the concerns is And this is actually an article that outlines some of the problems of how they're presenting themselves. And so not all of them are kind of going by the book, so that's the problem, is that when the FDA approves a medication, it's not just approving the drug substance. There's a lot that goes into
Yeah, I
making
worked
one.
at pharmaceuticals.
Oh, okay, perfect.
So I know.
So the other huge part that fortunately I don't have to deal with on that advisory committee is the manufacturing. Because if you can't trust the manufacturing process, you can't trust the drug. And so the problem is that these compounded pharmacies, sometimes they're getting kind of generic versions. And if you go to India, for example, so I was in India a year ago,
Yeah.
and the generic
Yeah,
drug
it's huge there,
industry is huge there.
Yeah.
And so because their cost of live, or what is it called, their GDP is lower, so certain countries like Bangladesh, and then for a while India, but not anymore, they could actually get these drugs that are approved here. The next day after FDA approval, they could get them there generically for example, for Ozempic, about $64 a month. And then for Zepbound and Mounjaro, it was about $84 a month. And the SGLT2 inhibitors, so like Jardiance and stuff, they could get those for pennies. And so it's a really, really different situation. I don't quite understand all of that.
Okay.
But you know, $84 a month is still a lot for someone who's making barely any money per month. So I think that's also relative. But I think the other argument that we're all making is that we think of the US as a wealthy country. Maybe it is on average, but it's actually not evenly distributed. So lots and lots and lots of people can't afford these medicines. We can't afford to pay for these super high prices that the US as a whole is paying. And so I think that's the argument that we're trying to make, that we shouldn't be paying and kind of subsidizing everybody else. And the drug companies should be kind of have more fair pricing. And so I think that, to go back to your question about compounded GLP-1s, I have some patients on them, and I feel good about the fact that people will tell me that they're on them, because I'd rather they tell me than not tell me. So I can just talk about it with them. And so some of the things I worry about are, I worry about how it's being made, I worry about contaminants, I worry about dosing. I think there have been many news reports, I mean, because we don't really see this, of people who it's just really hard to tell how much you're getting, because these pharmacies are not necessarily standardizing anything, and so people will get too much or overdosing accidentally, and then going to emergency rooms with acute kidney injury and things like that.
Yeah, well, they're coming in with dry powder compound, so you have to
Mix it up yourself.
Make it up yourself.
Yeah.
It is truly research grade product.
And I think when we say research grade, it sounds like it should be really great because it's research.
Yeah.
But I think what we're saying is that that's like what you can order from when you're in a lab and you're trying to test the compound in a petri dish or on animals. Like that's what we're talking about.
Yes.
Yeah.
Okay, I think we better wrap it up now.
Thank you so
all
much for your attention.
Yeah.